All right, good morning, ladies and gentlemen. Before I begin, I'd like to thank the selection committee for the opportunity to present our research here today. So I have no financial conflicts of interest to disclose, and of course the views expressed here are those of the authors and do not reflect the official policy of the Department of Army, Department of Defense, or the U.S. government. So blunt cerebrovascular injury, or BCVI, is an uncommon consequence of blunt trauma. However, it's been studied extensively in the adult population because of its high associated morbidity. As a result, screening criteria have been developed for use in adult population, and their use has been shown to markedly reduce the progression to stroke and improve outcomes. In contrast to the adult population, the incidence, optimal screening criteria, and outcomes for BCVI in the pediatric population are much less well defined. The majority of published studies in this population are small, single-center series, and as a result lack the power necessary for generalizability. And as a result, widely accepted guidelines do not exist. The criteria out there for kids include the East Guidelines, the Denver criteria, Memphis criteria, and the Utah score. Each one is composed of variably overlapping components initially validated in the adult population. And of course, when you talk about competing criteria, it typically means that there's conflicting results in the literature. Now, this table here summarizes the misclassification rate, which is akin to the false negative rate, and that's seen or noted in a number of these studies. And for instance, the East criteria misclassification rate ranges from a fairly respectable 9% all the way up to 33% in another study. And the other thing I want you to note here is that the number of diagnosed BCVI in these studies, which is typical of the literature, rarely exceeds 50 cases. But why does it matter? It matters because as many as a third of children, the reports may vary, may suffer an associated stroke. And it's such a vulnerable population with such a high long-term morbidity, it really demands our efforts to better understand this disease. So we sought to weigh into this debate by characterizing pediatric BCVI using a nationally representative cohort. In order to accomplish this, we utilized the Kids Inpatient Database, which is the pediatric version of the National Inpatient Survey. It includes about 1 million records annually, and we looked at years 2000 to 2012. And we included all patients from birth to age 20 with ICD-9 diagnosis codes corresponding to BCVI, and we excluded patients with penetrating injuries, their primary diagnosis. We utilized the validated ICISS methodology using the STATA ICD-PIC module, which gives us estimates of AIS and ISS scores. And we stratified patients by age. And we also stratified them according to the vessel injured. Our primary outcomes were stroke and mortality. Our secondary outcomes included patient demographics, injury pattern severity, as well as hospital-level characteristics, including size, status as a teaching center, and status as a freestanding pediatric hospital. And finally, we evaluated a number of risk factors for BCVI. These were identified, again, using diagnosis codes and are listed here. We also separately evaluated mechanism as a risk factor. And we then performed a multivariate logistic regression analysis to assess the level of impact of each of these risk factors on our primary outcomes. So what did we find? So we identified 1,182 cases of BCVI, which runs out to an incidence of about 20 per 10,000 cases. Interestingly, the rate or the incidence of BCVI increased significantly over the course of the study from the first 6 years at about 17% up to 28% for the last half. In terms of patient demographics, the patients were predominantly male and Caucasian. As you can see, the majority of patients were over 10 years of age. Carotid injuries made up the majority of cases, with vertebral and unspecified cervical vascular injuries making up the balance. Carotid injuries were slightly more common in younger children. Vertebral arteries were more equally spaced. Turning to our primary outcomes, so there was no difference in mortality, stratifying by age or vessel type. Interestingly, the rate of stroke was significantly higher in children 0 to 10 years, 29% versus 15% in the 10 to 20 years. Additionally, vertebral artery injury had a significantly higher associated stroke rate. I think this picture does well to kind of demonstrate that, that stroke rate is nearly double in those younger age groups compared to the older cohort, whereas mortality does not vary nearly as much. In terms of injury patterns and severity, older children were significantly more likely to be severely injured, and they had associated higher ISS mean scores. They also were more likely to have associated abdominal and extremity traumas. Turning to our risk factor analysis, so of the 7 factors studied, we identified 4 listed here, which were significantly associated with BCVI in the pediatric population. Now, I apologize for the busy table, but what I hope you can appreciate is that for ages 0 to 10, there were no significant association with any of these risk factors. And this suggests that these risk factors are of limited utility in that younger cohort. I'll just say briefly that hospital-level analysis demonstrated no significant difference in our primary outcomes. On our multivariate analysis, we found that severe head injury, carotid injury, as well as ISS were significant independent risk factors for BCVI-associated death, whereas carotid and vertebral injury, as well as female gender, were risk factors for stroke in pediatric BCVI, whereas age greater than 10 years was a protective factor. So only 2 studies to date have attempted to characterize pediatric BCVI in a nationwide cohort, and both focused on risk factors and neither used age stratification, making this the first study of its specific type. A number of trends emerged. First off, I alluded to already, was that relatively increasing incidence. Now, this could be due to an increasingly aggressive screening methodology. It's been advocated in adults when recognizing that a lot of BCVIs aren't diagnosed if asymptomatic screening criteria aren't used. Also not previously noted was the preponderance of carotid artery injuries. So honing in on our primary outcomes, we found that children less than 10 years old had double the rate of stroke, the older cohort. Now this is suggesting, or rather, though it had been appreciated that there's a high rate of stroke in pediatric BCVI, the fact that the burden falls unevenly on these young children had not been characterized. Further, this may be due to a number of factors, either sensitivity to hypoxia or possibly difference in biomechanics of the injury, the younger cohort. It's hard to say. Interestingly, though, there was no difference in the mortality despite the higher ISS scores among those older children. Additionally, we found that none of the risk factors we analyzed were significantly associated with BCVI in that younger cohort. And while we did find that mechanism was associated with BCVI in older children, it again was not valuable in the 0 to 10 age category. And this all highlights the need to consider dichotomizing BCI evaluation, because those younger children just do not appear to be well served by those criteria we examined. There are, of course, a number of limitations to this study. Some of them are inherent to the use of a large administrative database like the KID. We have limited information in terms of injury grade, for instance, as well as management through the use of antithrombotic or anticoagulant medications or surgical or endovascular therapy. We were unfortunately unable to assess any of the existing guidelines in their entirety. We had to pick and choose which ones we could identify using ICD-9 codes. And finally, due to our high rate of unspecified injuries, it limited the power of our injury-specific analyses. Overall, though, in light of the high rate of stroke, especially in that young population, in the younger cohorts, we would concur with the use of a broad screening stance in pediatric BCVI. Of course, this has to be weighed against the risks of ionizing radiation. And we would encourage the validation of alternative screening methods, MRI and ultrasound, and advocate further studies. So to conclude, this is again the first outcomes-focused nationally representative study of BCVI in the pediatric population. There's a high attendant risk of stroke and mortality, and though the mortality did not vary by age, the stroke was significantly higher among younger children. Importantly, age stratification was key in that younger children were not well identified using the risk factors we analyzed. And overall, we would absolutely encourage further prospective studies on this phenomena to improve screening strategies utilizing age stratification. Thank you all for your time, and I'm happy to answer any questions.
You had 5 seconds left on the clock. Good job.